call upon Dr. Sunil Jain. Dr. Sunil Jain is an emergency medicine head and consultant at Jaslok Hospital since last 7 years. His expertise is in handling all types of trauma and emergency in all age groups. He's worked in various reputed hospitals of Mumbai like Hinduja Hospital, Wakad Hospital and Nanavati Hospital as an emergency physician specialist. Dr. Sunil Jain. I also call upon Dr. Sanjiv Shah. He's an endocrinologist at Nanavati Max Super Speciality Hospital, Mumbai since 1991 to 2023. He's an academic clinician in private practices, 40 years clinical pharmacology, KM Hospital, herbal drug research at Spark 10 years and researcher in global trials in diabetes. 50 original research papers and 20 book chapters, regular teaching faculty, national conference. Dr. Sanjiv Shah.
Now, Dr. Sunil Jain will speak on SGLT2 inhibitors versus GLP1 RA agonists.
Good afternoon, everyone. So I'll be just taking you through SGLT2 and GLP1 in the next 10 minutes. So these are all the SGLT2 inhibitors which we have available right now. The last Bexa2 is not available, rest all are there. So the action is the glucose absorption is in the proximal convoluted tubule is active process. SGLT-R is coupled with MAP17 protein and it mediates 90% of the glucose reabsorption in the S1 segment and SGLT-T1 which is 10% in the S3 segment. So you have more of glycosuria which result in when maximum resorptive capacity is exceeded. So this is the way action is there. So what are the factors determining the efficacy? Hyperglycemia, GFR and renal threshold. So the efficacy depends on filtration load and renal threshold. Filtration load depends on the glucose level and the GFR. Increase in the renal threshold, it is individual variation, so you cannot comment. So it depends on the individual to individual, the renal threshold. So if all are high, the efficacy is always high. So in just, this is the cardiometabolic effect of SGLT2. I think everybody is aware of it. I'll just go quickly. So clinical implication, so it was developed and approved for diabetes management in 2013. It's anti-diabetic agent by glycosuria, but recently everybody knows it's a cardio-renal drug moreover than the diabetologist. Risk like an hypovolemia, hypotension, electrolyte disturbance were not observed in clinical trial. Increase in glucagon levels and increase the EGP. Increase in genitourinary infection, which is most common. Effect independent of the beta cells, so 40 to 60 grams of glucose lost there in urine. Additional benefits are heart failure and CKD. So FDA has already approved EMPA and DAPA for reduced ejection fraction. So action, there are multiple pathways, but these are all hypotheses like blocking of the sodium hydrogen one in a cardiomyocyte. Ketone will be acting as a superfuel, reduce the free radical formation in the cardiomyocytes. It improves the coronary endothelial function and flow-mediated vasodilation, reduce adipose tissue around the ventricles, aorta and the coronary arteries, and weight loss, BP reduction, reduction in the preload, and reduces the SNS tone and RBC mass. It's also approved in CKD, so FDA has already approved. The action is restoration of the tubulo-glomerular feedback, reduce in the proximal convoluted tubule hypoxia, blocking the NHE3 in proximal convoluted tubule. Ketone again is act as a superfuel, stimulates the EPO synthesis and improves the hemoglobin, and BP lowering effect I already told you, glycemic control. So where to use, which is more important? So these are the one which we have placed in practice. HbA1c lowering effect, mild to moderate, useful as a next add-on agent with an existing therapy for a diabetic, first to third line. Heart failure and chronic kidney disease, irrespective of the glycemic control. CV protection, mainly in the heart failure. Renal protection. Weight loss is an additional benefit. BP lowering effect may be beneficial for NAFLD or NASH. So CV protection is the mainly which is heart failure which is used. Recommended based on the GFR, it's an important slide. So more than 60, DAPA is safe. Can I start at 100, increase to 300? EMPA start at 10 and increase to 25. 40 to 60, it's DAPA is still safe. CANA is also safe. EMPA start at 10 and increase. 30 to 45 approved for EGFR more than 25 for DAPA, approved for use in dose of 200. And EMPA is approved for EGFR more than 30. And less than 20 to 25, not to start any drug. So it is not till approved, but yes, for more than 30, it is approved. What are the risks and reason for discontinuation of SGLT2? So risk is urogenital, osteoporosis, DKA, Fournier's gangrene. They comment, but I have not seen any patients till now. I have been using it. Low limb amputation, yes, it was more with CANA. Weakness we can get, avoid in elderly and frail patients. So these are the green signals to use like. So otherwise, healthy patients, please go ahead. Overweight or obese patients, no history of any UTI or genitourinary infection, albuminuria, EGFR more than 20 to 25, HFrEF, moderate ejection fraction, heart failure with preserved ejection fraction, all. Type 2 diabetic with a high insulin requirement and established CVD. So this you can safely use. With a caution, yes, ongoing weight loss, history of, again, genitourinary with UTI in last 1 year, osteoporosis or fractures, high HbA1c and a low C peptide level. Low urinary tract symptom, BPH and nocturia, history of peripheral arterial disease, and BMI less than 20, elderly with nocturia. So here you have to use with cautious. So don't break the traffic. So red light, it's alert, red flag, acute illness, NBM, catabolic, recurrent UTI, postural hypotension, history of diabetic ketoacidosis or suspecting a LADA patient, EGFR less than 20 to 25, previous history of lower limb amputation, high dose steroid therapy, and pregnancy and lactation. So you are supposed to avoid. So in a nutshell, this is a slide for you. Incretin base, this is my next topic, GLP1. Sorry, you want it here. GLP1, so I'm being given this also, I'll talk on this. So basic concept, GLP1 is a very potent insulotropic substance. Okay, pharmacological, GLP1 levels can restore impaired insulin secretion. So higher the GLP1 level, higher is the insulinotropic response you have. For satiety, further higher GLP1 levels are needed, and higher GLP1 levels causes nausea and weight loss. So this is the effect. So at the end, in the brain, satiety, delay in the gastric emptying, stimulation of insulin secretion, inhibition of the glucagon secretion. At the end, improve glycemic control and reduction in body weight. So GLP1 accounts for more than 60% of total insulin release after a meal. So these are character: route, injection, and oral is available. GLP1 levels high you required for weight loss. Limited by endogenous secretion is not affected. GLP1, DP4 is affected there. Efficacy-wise, it is more efficacious. Weight loss, yes, there is a weight loss. Nausea, you have some amount of nausea. So these are the classification-wise. So you have exendin-based, there are exenatide, lixisenatide, exenatide LR, human GLP-1, that is liraglutide, which is injectable. You have a weekly-based, which is dulaglutide and semaglutide, and oral, which is right now we have semaglutide. So Victoza, Trulicity, Lixumia, Rybelsus, which is the oral one. So the main side effect related to delayed gastric emptying and to be avoided with the high risk of pancreatitis. So if you have a patient with a pancreatitis, please avoid this. This is the action for oral, which is there. So oral semaglutide you have to take up when you woke up on an empty stomach. So take directly straight with a half glass of water. Okay, wait for at least 30 minutes before eating or drinking anything else. So you start with 3 milligram. After a month, you see how the patient tolerates, switch to 7 milligram. And if the patient tolerates, then 14 milligram is the one which is there. So ideal candidate for GLP-1 is maintaining or gaining weight, increased appetite, uncontrolled glycemia, post-meal high glucose, interested in weight loss, interested in flexible lifestyle, and can afford, because these are all costly. So barriers to GLP-1 analog therapy, injectable route. So there were patients who are saying that we don't want injection, but right now you have an oral also. Duration of the treatment, yes, it's a prolonged treatment which is there. Cost and habituation. So how to overcome? Patient education, explaining the concept about the GLP-1. Availability is there in oral formulation now. Advantage of weight loss, no hypoglycemia, no dose adjustment, reduction in oral anti-diabetic, weight loss, and maybe a beta cell preservation. At present, we have in India approved is only Wegovy and Ozempic, which I think yesterday Tushar sir already explained. So these are the only one which is approved for injectable. Rest is oral, which we have. Thank you. I think I have completed in 10 minutes.
Yes, sir.
And I'm really sorry, I was fast, I knew. But I was told to complete in 10 minutes. Thank you.
Dr. Sanjiv Shah will talk on diabetes vascular damage to understand aging.
So at the outset, I would thank Dr. Preeti Bhargav for inviting me in this GPA meeting. Now, first of all, as this was going to be on GLP1 and SGLT2 inhibitor, I thought I would add just 1 minute, which was saved by Dr. Sunil. So GLP1 RA act through all 8 pathophysiological pathways. No oral drug addresses all the pathways. So this, instead of a multiple drug being combined to treat diabetes, you act on the liver, reduce insulin resistance, not only works on beta cell, but it also works on alpha cell dysfunction. Increased glucagon is an abnormality. It reduces this, so it prevents hypoglycemia. No other drug reduces appetite, so this is unique in that way, and that's why it is anti-obesity. People do truly eat much, much less. One thing which you do not find here is an increased gastric emptying time. Patient feels so much full that cannot eat the next meal and would eat significantly less. So in patients with GI disorders, do not use this drug. Be careful, there is a black box warning. Some of the patients with gastroparesis and whatnot. But this should be the first injectable drug before insulin. Most endocrinologists prefer to use this instead of insulin. In India, it is there since 15 years. More than 1,000 patients I have treated with this class of agent once a day. The only difficulty was 300 rupees a day. In a 1 month time, biosimilar made in India, liraglutide would be launched at a price of 100 rupees a day. Ozempic, what Dr. Sunil talked, is available in black market. Many of my patients are taking at 15,000 rupees weekly injection, 60,000 rupees a month. And all celebrities and those who want to use, they take away from the market, but they are using it. Coming to the next point, there had been multiple CV outcome trial, and this drug works on anti-atherosclerotic pathway. SGLT2 inhibitor have good CV outcome, but only heart failure, hospitalization, and CV mortality, while GLP1 RA work on atherosclerosis development. I have summarized SGLT2 inhibitor in a single slide. On the left, glycemic benefits, new pathway to control diabetes independent of beta cell. You don't need beta cell function. Whatever is the duration of diabetes, it doesn't matter. A1C reduction is to the tune of 0.7 to 1%, matching with all other class. But higher the baseline, as you see here, more than 9%, more than 12%, the effect would be larger. It eliminates 70 grams glucose equal to 300 calories equal to 20% of food, but only 3 kg to 4 kg weight loss in most people. But there is blood pressure reduction, fluid loss, heart failure, all classes, CV protection, renal protection. I can't go into the details of it. You will get plenty of opportunity to learn. So I would go into the different topic. SGLT2 inhibitor reduce 4 millimeter of systolic blood pressure. But it reduces sympathetic nerve activity, salt sensitivity, natriuresis, body weight, arterial stiffness. Why people don't die on SGLT2 inhibitor? Maybe an arterial stiffness which is being investigated. And reduces nocturnal hypertension. Probably nocturnal hypertension is not well understood. I don't know, nobody, plenty of diabetologists in the country, nobody practiced hypertension specialist. 40 years back when I started practice, Dr. Ashok Vaidya told me, don't practice diabetes, practice hypertension. He practiced as specialist in hypertension. When 1 in 4 individual has hypertension in India, ICMR and all new research epidemiological data, 1 in 4 has hypertension. Diabetes is only 1 in 10 individuals. So hypertension is far more common. So in next 25 minutes, I am going to teach you what is going to be an aging, what is an vascular aging, and how we age. I do not look at glucose disorder as being something. It is actually, diabetes is a vascular disease in which hyperglycemia is a late manifestation. So people start with something else in the advance, vascular damage even on the day 1 diagnosis of diabetes, or even when there is pre-diabetes. We were glucose-centric, now we are no more glucose-centric. So you can see chronological aging. Many of us are, at least my analysis says that biologically I am 10 years younger, vascular probably still younger, physically I am struggling to become 10 years younger, mentally 20 years younger. As it was defined, the man is as old as his arteries. So if you have to survive longer, you will have to prevent a vascular disease, malignancy, and probably an accident. Death certificate analysis revealed 3 causes at the top 3 causes of death. Accident has gone lower. The other 2 still continue, vascular disease and malignancy or cancer. So this is aging related disorder. There is still no single drug to inhibit fibrosis, fibrotic pathway. 5% of death occur due to cardiomyopathy, pulmonary interstitial fibrosis, cirrhosis of liver, and few more disorders in different, for example, myelofibrosis. So all these are single pathway which are driving tissue towards fibrosis, different organs, different manifestation, different label. But there are more than a dozen drugs currently in pipeline, we don't know what will come out, which would prevent many of these fibrotic disorders. If you see the stroke, atherosclerosis, diabetes, all these are vascular. Alzheimer is a degeneration. Probably I won't be talking today on musculoskeletal health and aging, or brain aging, or a decline in brain. So this is kind of a nice illustration, though published in JACC, which is a cardiology journal in 2020, which looked at all the risk factors in relation to aging all over the body. But if you want to live longer, in longevity, you will have to prevent cancer, neuronal cells. You will need a good body to survive beyond 80, probably beyond 75, if you want to go towards 100. And many senior citizens develop respiratory or other infectious disorder. So immunity goes down, and we have no easy solution for these issues. I will show you one elegant paper done in New Zealand. We believed that at what age the aging starts. It could start very early, very young, but I was surprised to read this paper published very recently in Nature, which looked at 6-year interval the people at 26, 32, 38, and 45, 6 years interval. And this paper, when published, the data of 38-year people, there were many people, 20% had aged 6 years more than 38, but there were also 20% people who were 6 years behind. At the age of 38, they were like 32. This was very intensive search on aging, and you can see from BMI, so this is adiposity, A1C, all pulmonary parameters, lipid parameters, EGFR, high sensitive CRP, WBC, but they also estimated functional and structural MRI. They did very intensive studies on brain age. They looked at cognitive, sensory, locomotor, everything. Even they evaluated dental and independent opinion on the face, looking at an individual, what could be the age. So look at the biomarkers of aging. This is Walter working in California and Italy, a different individual, not a New Zealand study. He is also one of a pioneer in aging. Insulin resistance, fasting glucose, A1C and adiposity. Lipid parameters on vascular side is pulse wave velocity, LV diastolic function and pressure. Inflammatory markers, renal clearance. Frailty measurement, plenty of them. Someday this is very interesting topic. One leg stand or stance test is an important marker that you will not fall and not develop a hip fracture. Cognitive performance, lymphocyte number, IGF is the one which drives into a malignancy. So if people have to prevent malignancy, you will have to have a lesser amount of circulating insulin and insulin growth factor. There are biological vascular age indices. Earlier I talked about in general aging. This is in relation to cardiovascular risk factor. If you have to relate to various things where the blood vessel is linked, vascular aging, as simple as salt intake, sugar intake, meat intake, fat intake, and pulses intake are related. This is a science report in 23. All lipid parameters, even a white cell count, this is body fat, age and everything. They came out with systolic pressure, ankle brachial index, diabetes related blood flow, intima media thickness in carotid, and multiple 9 ways in which vascular aging could be mapped. This is all molecular and cellular, so don't look at this, but if you look at functional and structural, arterial stiffness, blood pressure, endothelial dysfunction, and atherosclerosis. So this is again a Jack trying to tell us that these are equally an important parameter. Now, if I tell you about diabetes and vascular aging, on the day of diagnosis of diabetes, about 1/3 of people have carotid intima media thickness suggestive of an atherosclerosis on day 1. If you do a microalbuminuria in newly diagnosed people, 1/3 will have microalbumin positive. So an albumin leak in the kidney is present in 1/3 of the people. So already a endothelial dysfunction, the most important marker, is already there in diabetic people on day 1, and they will progress further. Now this is vascular biology of aging and implication in hypertension. Hypertension is larger. This is molecular cardiology. And they looked at 4 different parameters. If you look at vascular inflammation, endothelial dysfunction, and remodeling. If you go upwards, you will find vascular relaxation versus reactivity, backward into the molecular pathway, similar various cytokines having inflammation. This is on fibrosis, stiffness, and calcification of blood vessel, which would decide on backward pathways. Maximum work and an intervention and anti-aging drugs are on SERT and FOXO pathway to prevent autophagy, senescence, and apoptosis. These are the drugs which are being developed for longevity. Some of them are available. Metformin is one of them. Coming to the further on hypertension, why nocturnal hypertension is important and 24-hour ambulatory BP is important in all hypertensive people. Just one office BP does not diagnose or does not tell you everything. You need a 3 times reading for every single BP reading. You need a supine and standing. You need at rest and after 6 minutes walk. you need at rest and staircase climbing, and you need a 24-hour BP. So nocturnal dipping of blood pressure not happening is an abnormal circadian rhythm, and this would predict more than an office BP about the development of future cardiovascular events or a heart failure. The key mechanism are salt sensitivity and increased sympathetic activation, but the intervention drugs are ARNI, SGLT2 inhibitor, mineralocorticoid receptor antagonist. Simplest and oldest is spironolactone, which is currently recommended in resistant hypertension, but the eplerenone and newer one, finerenone, have become more popular. These are the 4 drugs: MRA, ARNI, SGLT2 inhibitor, and renal denervation. All of them reduce nocturnal hypertension, LV hypertrophy, improve renal function. Thereby, these are the 2 markers of 2 different organ function. This is cardiac, proBNP, which is a marker of myocardial stretch, and this is kidney disease. Simply telling you the meta-analysis of antihypertensive, 10 millimeter lowering of systolic blood pressure would benefit. This is 20 studies, 17 studies and all that. CV disease, mortality, CHD, maximum benefit in stroke, heart failure, renal, retinopathy and albuminuria. 10 millimeter. So 140/90 is okay, chalta hai, is all wrong. If you really want to prevent, it has to be 130. Sprint study showed 120 in non-diabetic population. This is just trying to show you that in diabetic people, we don't use a single monotherapy antihypertensive. We should be using a combi. So angiotensin receptor blocker and a calcium channel blocker combination is considered one of the best. And this is what is multiple studies, meta-analysis show that this combination is one of the best antihypertensive in diabetic people. No increase in side effect compared to other combination. This is a combination of ARB and CCB, and these are other combination. You will find the difference in even a CV event. So ARB and diuretic, ARB and beta blocker, all are available, but ARB and CCB is superior to others. Getting away from hypertension now into atherosclerosis, vascular, another phenomena. This is the progress of people over the age. We believe that atherosclerosis could be starting at 40, but now it could be much, much earlier. We do not know at what age it starts. So people progress, you pick up when the clinical event happens, which is called an endpoint and an event. People do have a silent atherosclerosis. 2/3 of diabetics have asymptomatic atherosclerosis. Now, more than 2 million participants and 20 million person years of follow-up show that LDL is the culprit. And how much LDL? So I will show you a concept of lifetime exposure of an LDL. When you get a 7,000 LDL as your number, this is a multiplication. If you see here, this is cumulative LDL exposure, total exposure multiplied by milligram multiplied by years. So if you keep 100, you will have event by 70 years. But if you keep 70, you may not have an event till 100. This is where it is LDL. This is age 50 to 70. And this is what is a possibility of event. LDL 125. Kaushik Ray in UK and Brandt has written just 2-page beautiful paper. Somebody should read on this. This is lifetime exposure, 7,000, degree of elevation and duration of exposure. This is all the clinical trials, including Mendelian studies of 52 years, 1,94,000, magnitude of exposure. With the statin adherence, which is 25% less than recommended dose being taken by people, we can hardly prevent a cardiac disease. But if people do manage to have LDL below 70, rest assured that CV event is likely to be. Lower the LDL, better. Earlier initiated, better. This is all the statin trials put up here, primary prevention and secondary prevention, before and after. This is LDL in millimole, 1 millimole is 38. And as it is lower and lower, the CV event rate is lower. Side effects of 5, 10, 20 and 40 rosuvastatin is identical. All the doctors and patients believe that statin muscle pain is 20%, but all the clinical trials and data show it is 9%. So true statin intolerance is extremely rare. There are ways to diagnose and ways to handle. Evidence is lower the better, longer is better, lower is better, and earlier is better in relation to prevent any kind of a vascular major disease, whether it is a stroke. This is at any given age, any background disease except an advanced liver disease. In all the different studies. Now, how does this vascular damage happen? So I put up here, these are molecular factors, these are vessel wall component, these are alteration, and these are the disease vasculopathy. Hypertrophy, cytokine and proliferation, vasomotor. This is matrix regulation. With LDL, if it gets oxidized, it will create atherosclerosis. With blood pressure, you have a barotrauma. In all these people, diabetics or hypertensive, there is renin, angiotensin, RAS activation and sympathetic nervous system activation. IR, IGF and glycation is a glucose-related damage. With obesity, you have inflammation, NF-kappa B and oxidant damage. Endothelial dysfunction is there in all these people. And there are all growth factors which result into multi-pathway damage. So where do you get a vascular damage in diabetic? Practically all the tissues and all the complications. The prevalence rate is like this: coronary heart disease, heart failure, peripheral, stroke. Percentage is written on all. This is European Journal Preventive, retinopathy, neuropathy and nephropathy. Everything is vascular in diabetic people. I have 8 minutes to go. Subclinical atherosclerosis in pre-diabetic people, and you can see in coronary artery, HbA1c. Look at this A1c, this is from 4.8 to 6.1. Up to 5.6 you will find the same, but as A1c increases to 5.7, 6 and more than 6, you have increased coronary calcium score. This is carotid artery and this is peripheral artery. This is pre-diabetes. This is not diabetes. So before diabetes starts, damage is already there. Each 1% increase in uncontrolled.
You have 15 minutes.
Whatever, so I will finish whatever slides I have. And then people will have a lot of questions, but everybody wants to increase the lifespan, but we all are late who are sitting here. So I will tell you the secret at the end if I have finished the slides. So I will tell you the fasting blood sugar. This is 7 lakhs people, 52,000. This is some old Lancet paper. They connected fasting blood glucose and risk of vascular disease, 102 studies. So there is a relationship with fasting blood glucose, relationship with HbA1c. But I will show you something different. Try to read this. I'll explain this. Now this is 1 hour post glucose value. 1 hour post glucose was never done as a part of recommendation. These are half a dozen studies, many of them are cardiac studies, and 1 hour value predicted future cardiovascular disease. 1 hour post glucose value is not pre-diabetes, it is pre-diabetes. So diabetes happens, before that is pre-diabetes, and before that is pre-diabetes. So 1 hour value of 155 155 value is a predictor of future diabetes, future cardiovascular disease, future retinopathy, and everything. So this is association of 1 hour postprandial glucose or a post-glucose value. These are multiple studies and multiple subjects. But this never became popular. I will show you another paper. 1 hour post-glucose is a predictor of retinopathy risk compared to 2 hours. So even 155 in 1 hour will send the signal to retina on a complication pathway cascade. It's a trigger which goes further even if 2 hours value gets normalized. So allowing people to have even an immediate short lasting hyperglycemia is a big challenge. Coming to another vascular phenomena is an albumin excretion rate when the blood is getting filtered in nephron and the albumin is going to leak. This is normotensive diabetic, this is non-diabetic hypertensive, and this is diabetic hypertensive. So double trouble is a word used for diabetics and hypertensive. 58% of people will have diabetes and hypertension, microalbuminuria. See, in the past, a kidney association defined chronic kidney disease based on an eGFR, creatinine calculated as eGFR. Every lab report should have ideally an eGFR. But now the kidney association defines as microalbuminuria as a chronic kidney disease and an eGFR of 60 as a CKD. I don't know why we have to wait from 90 to 60 fall to call it a kidney disease. iCare registry of diabetes in India showed that 64% could be defined as a kidney disease. But arbitrarily you could say 50 or 60% of people, diabetics, have a kidney disease. Now what is the significance of early detection of microalbuminuria? This is nephrology paper which looked at cardiovascular events, cardiovascular death, and then renal events. 1.6-fold, 2-fold, and 3-fold. So this is a predictor of a future event. So you define the people into a risk category and act accordingly. Everybody looks similar as a glucose disorder, but you don't act. So you need a risk prediction. So I take you into how do you predict a risk when individual sitting in front of you. This is called a Bravo risk engine, published in American Diabetic Association Diabetes Care. Don't look at this Sadia Khan, which is going to show you in the next slide, which is just published couple of months back in Circulation, a new paper. They looked at A1C, systolic BP, LDL, and BMI. In all 3 CV outcome trial, which Dr. Sunil mentioned about the CV outcome trial in SGLT2 inhibitor, they used the data and they calculated. But now American Heart Association came out with a new equation called PREVENT. They looked at kidney, tobacco use, diabetes, medication. They took all these parameters, but they took urinary albumin creatinine ratio. So this is new prediction equation published last month in American Heart Association journal in Circulation. And this is going to be a predictor of. Now what we already know from Framingham risk equation, Reynolds score, then CV risk calculator in Europe is called a score, but Joint British Society, British people are somewhat matching with Indians and they have a Q risk score. There was first equation, second equation, and now a third equation. So Q risk score matches much more than a Framingham. Now I am going to show you that we knew that the standard risk factors were age, sex, total cholesterol, HDL, diabetes, hypertension. What about a new risk factor, what we see today? And these are there in all this new Q risk score. ethnicity, deprivation, social issue, obesity, CKD, atrial fibrillation. Very important is systolic blood pressure variability. This variability is a new emergent phenomena, glycemic variability, pulse variability, and systolic BP variability. So science is getting refined, and future papers based on artificial intelligence will give you all this, everything into the new research paper. But mental illness, antipsychotics, erectile dysfunction, steroid, and all this, I have not put it air pollution. There are papers on air pollution, what air we have in Mumbai, Delhi, is also a risk factor for heart. So this is now a new paper of Sadia Khan, which tells you, called cardiovascular, kidney, and metabolic risk. So these are the stages. Dysfunctional adiposity. In the last slide, I will show you what is dysfunctional adiposity. Metabolic risk, subclinical CVD, predicted CVD, and a clinical CVD. Where the patient is and how patient is treated will determine what it is. Simply now, next 6 slides, how to prevent. So this is American College of Cardiology, physical exercise, low salt, try to go to 6 grams salt a day, healthy dietary pattern, restrict calorie, prebiotics, anti-inflammatory cytokine agents, antihypertensive, aspirin, statin, resveratrol, metformin, and rapamycin. This is what is anti-aging vascular protection. Longevity, blue zone, 5 locations in the world where there are centenarians living more than 100 years. Okay, these are the 5 locations. If you study their lifestyle, why are they 100 years? They have postponed beyond 80, IHD, stroke, cancer, infection, diabetes, and dementia. Increase intrinsic capacity to respond to minor stresses of daily life. That results into slow physiological decline. Luxury is bad. Challenging the body to withstand is necessary if you want to live long. High amount of legume, Mediterranean diet, calorie restriction and fasting, and healthy gut microbiota. No adverse effect on anything. Look at the lifestyle of these centenarians. No overeating, strong family connection, practice less but enjoy other things of life, close social engagement, meaningful life purpose, low level of physical activity, staying stress-free, moderate alcohol, and a belief in high power. Laughing is extremely important. Tushar, laughing is very important, and a socializing. 2 slides on exercise, acute molecular choreography of exercise. This is adversity. If you allow your body to subject to a good exercise or intensity exercise, you create an adversity in the body. And that challenge helps you to survive longer. There are multiple metabolites which have been estimated in a sophisticated experiments. This is a paper in Cell Biology which has looked at, but I'll show you this exercise which looked at 502 metabolites in a heart study. Framingham participants improved with an exercise of 12 minutes intensive exercise, favorable change which are associated with lipolysis, nitric oxide biology, and adipocyte browning, which is associated with metabolism. This is on calorie restriction and intermittent fasting. This has a preventive on a pathway of autophagy.
So last 2 minutes.
Yeah, so we'll finish in 2 minutes. Reduction in apoptosis and aging. This is a method of cancer prevention. Calorie restriction, predominantly carb restriction. 20% less calorie consumption will add 10 years in life. So this would also prevent brain aging and decline. But all the benefits of diet and exercise was lost. There was a paper recently 6 months back that if a person does not sleep 7 hours, cognitive decline benefit of a diet and exercise was lost. So 7 hours sleep was considered mandatory if you want to prevent cognitive decline. Now this is a difference between calorie restriction versus intermittent fasting. Intermittent fasting is a time restricted eating, but does not necessarily mean 20% less calorie. So this calorie restriction probably could be achieved with intermittent fasting. This is again a recent paper in aging, and all the pathways of age-related disease would be prevented and inhibited. So this is a slide on dysfunctional adiposopathy. This is pre-adipocyte, adipocyte, and macrophage. So as the cell size of adipocyte increases, there is release of free fatty acid, pro-inflammatory cytokine, impact on fibrosis, and inhibition of insulin action. So have you heard of Life Essential by American Heart Association to prevent heart disease? These are the 7 parameters, but the 8th was added as important as a sleep, get healthy sleep. So this is the last slide. Thank you for listening this lecture.
Thank you, sir. May I call upon...
This was a slide to support Sunil that this many trials are done for SGLT2 inhibitor in a kidney disease.
May I call upon Dr. Sunita Manglik to felicitate Dr. Sunil Jain. Dr. Sunita Manglik. And Dr. Kumud Dalal, Treasurer, Kumuda Dalal, to felicitate Dr. Sanjiv Shah.